Hi everyone, our subject today is neutropenia in pediatrics. Basics. Neutropenia defined as an absolute neutrophil count less than 1500, which is considered mild. Moderate less than 1000, severe less than 500, very severe less than 200. Absolute neutrophil count vary with the age and race. The severity of neutropenia is helpful in predicting an increased likelihood of pyogenic infection. Neutropenia is a common finding in pediatric patients. Most often, this is transient and related to a viral infection or another transient cause. Rarely, it can be associated with congenital neutropenia syndrome. The major associated complications include bacterial and fungal infection, which usually arise only when the neutropenia is severe and prolonged. History of recent or current viral infection, current or recurrent fever, skin abscess, infection, or oral ulceration, temporal pattern of symptoms of malabsorption such as diarrhea or failure to thrive, delayed cord separation, medication use or toxin exposure, diet, evidence of nutritional deficiency, developmental history, ethnicity, family history of neutropenia, recurrent infection or early death, consanguinity, short stature, dwarfism, skeletal abnormality, and albinism. Result of a prior complete blood count with differential, prior normal white BC count, and absolute neutrophil count essentially rule out severe congenital neutropenia. Severe neutropenia with count 500 is associated with the greatest risk of pyogenic infection, including cellulitis, abscesses, including perirectal, furnicles, pneumonia, septicemia, as well as oral infections such as stomatitis, gingivitis, and periodontitis. Physical examination, a growth curve, oral ulceration or gingival irritation, phenotypic abnormality like thumb anomaly, dwarfism, partial albinism, hepatosplenomegaly or lymphadenopathy, bruises, petechia, pallor, birthmark like cafe-au-lait spot, neurological examination, signs of infection, fever, temperature should not be taken rectally, tachycardia or hypotension, pharyngitis or thrush, cellulitis, perirectal or labial abscess, sign of local infection such as inflammation, pus, may be diminished due to lack of the neutrophil. How to approach the child with neutropenia after performing history and physical examination. Patient needs complete blood count with differential and peripheral smear. Is there pancytopenia? If it is yes, this will be discussed in another lecture. If it is no, there is no pancytopenia. Is there history of a drug, chemotherapy, or radiation? If it is yes, this is a drug-induced neutropenia, like anticonvulsant, phenytoin, carbamazepine, antibiotic, chloramphenicol, penicillin, sulfonamide, analgesic, morphine, indomethacin, antithyroid drug like propylthiouracil, cardiovascular like quinidine, sedative like phenothiazine, chemotherapy, hypoglycemic agent like chloropropamide, or radiation. If there is no history of a drug intake or radiation, is the child ill-looking, febrile? If it is yes, consider bacterial, viral, or fungal culture PCR. This is either viral infection, bacterial infection, congenital acquired neutropenia with the superimposed infection, or severe malnutrition. If the child look well, recheck in 2 to 4 weeks depending on the absolute neutrophil count. If still neutropenic, check white BC count twice weekly for 6 to 8 weeks. White BC normalized, this is viral suppression. Cyclic change in white BC count, this is cyclic neutropenia. If neutropenia persists, this is chronic neutropenia. Is there phenotypic abnormality present? If it is yes, this is either Chidak-Higashi syndrome, dyskeratosis congenita, Shwachman-Diamond syndrome, or cartilage hair hypoplasia. If there is no phenotypic abnormality, as we mentioned, if there is no phenotypic abnormality, patient need anti-neutrophil antibody, Coombs test, and immunoglobulin level. If it is abnormal, this is autoimmune neutropenia of infancy, immune neonatal neutropenia associated with immune disorder. If it is normal result, consider B12 and folate level, copper level, HIV test, and bone marrow examination. Differential diagnosis: nutritional deficiency, splenic sequestration, metabolic disease, glycogen storage disease, reticular dysgenesis, severe congenital neutropenia, benign familial neutropenia, and HIV infection. Fever and neutropenia. In patients with fever and neutropenia, particularly if the child is ill-appearing, culture of blood, urine, and any suspected site of infection should be done. Antibody response, antigen detection test, and polymerase chain reaction method may also be useful. In patients undergoing chemotherapy, culture should also be obtained from central venous line. These should include aerobic and anaerobic bacteria as well as fungi. In chronically infected site, mycobacterial and anaerobic culture are recommended. If diarrhea is present, obtain stool culture for bacteria, virus, and parasites. Clostridium difficile toxin should be sought. Test for certain virus may be considered in a specific instance. For example, herpes cell culture and PCR testing from vesical skin lesion, or PCR testing for respiratory viruses in children with respiratory symptoms. It is important to note that mild neutropenia in a child with the febrile viral appearing illness and without history of recurrent significant infection may not need further evaluation. Transient neutropenia with viral infection. The most common cause of transient neutropenia in children is viral infection. Viruses commonly causing neutropenia include hepatitis A and B, respiratory syncytial virus, influenza virus type A and B, measles, rubella, and varicella. It may also occur in early stage of infectious mononucleosis. Leukopenia may be seen in patients with HIV infection. This may be due to virus or due to antiviral drug. Bacterial infection with neutropenia. There may be neutropenia associated with typhoid, paratyphoid, tuberculosis, brucellosis, tularemia, and rickettsial infection. In patients with immune deficiency, commonly cultured organisms include Staphylococcus aureus, coagulase-negative staphylococci, and gram-negative organisms including E. coli and Klebsiella pneumoniae. Candida may also be cultured. Nutritional neutropenia, severe malnutrition seen in anorexia nervosa and marasmus may also cause neutropenia. Nutritional deficiency, including those of vitamin B12, folate, and copper, may also be associated with neutropenia. Cyclic neutropenia is a congenital condition with regular fluctuation in the neutrophil count. The nadir occur approximately every 21 days, often to an absolute neutrophil count of 200 cells. During the neutropenic period, there may be fever, oral ulcer, gingivitis, periodontitis, and pharyngitis with the lymphadenopathy. More serious infections such as mastocytitis or pneumonia may also occur. Although any severe infection may result in neutropenia, cyclic neutropenia and chronic neutropenia need to be excluded with the twice-weekly white BC count for 6 to 8 weeks. Reticulocyte, platelet, and other leukocyte count may also cycle. Congenital neutropenia. Chidak-Higashi syndrome is characterized by oculocutaneous albinism. There is an increased susceptibility to infection due to neutropenia as well as defective function of the remaining neutrophil. This keratosis congenita is associated with a nail dystrophy, leukoplakia, and reticulated hyperpigmentation of the skin. Shwachman-Diamond syndrome is characterized by dwarfism, growth failure, skeletal abnormality, and exocrine pancreatic insufficiency, causing diarrhea, weight loss, and failure to thrive. Cartilage hair hypoplasia features neutropenia with the short-limbed dwarfism and fine hair. Reticular dysgenesis, which is characterized by neutropenia and lymphopenia. Lymphoid tissue absent, lymphoid tissue like tonsil, lymph node, Peyer's patches, and lymphoid follicle. All of these are absent. In severe congenital neutropenia, the absolute neutrophil count 200 or less, it present in young infant with severe pyogenic infection of the skin, mouth, and rectum. It has an autosomal dominant form and recessive form like Costman disease. Autoimmune neutropenia of infancy usually present between the age 5 to 15 months. Patients usually have severe neutropenia with an absolute neutrophil count 500. However, the total white PC count is usually normal. Diagnosis is usually by the presence of anti-neutrophil antibody, but multiple screening may be needed to detect these and avoid the need for bone marrow study. Immune neonatal neutropenia is similar to Rh hemolytic anemia. It occurs due to maternal sensitization caused by fetal neutrophil antigen. The neutropenia may last for weeks and as long as 6 months. Anti-neutrophil antibody are found in the maternal and infant serum. It can also occur in infants whose mother have autoimmune neutropenia. Disorder of immune dysfunction with neutropenia. These conditions include X-linked agammaglobulinemia, hyper-IgM syndrome, cartilage hair hypoplasia, and HIV infection. Reticuloendothelial sequestration secondary to splenic enlargement can lead to neutropenia. Causes include portal hypertension, splenic disease, and splenic hyperplasia. Metabolic disease that associated with neutropenia, hyperglycinemia, this is not hyperglycemia, hyperglycinemia, isovaleric acidemia, propionic acidemia, methylmelanonic acidemia, and tyrosinemia. Neutropenia may also be noted in some glycogen storage disorder like type 1b. Patient may present with hepatomegaly, hypoglycemia, elevated lactate, cholesterol, triglyceride, and uric acid level, as well as associated neutropenia. Familial benign neutropenia is mild with no increased tendency for infection. Frequently asked question, do all patients with neutropenia require colony granulocyte colony stimulating factor? Answer, no. Patients with severe congenital neutropenia have fewer infection when treated with the granulocyte colony stimulating factor. Patients with the benign neutropenia generally do not need GCSF. Question, can a neutropenic patient receive vaccination? Answer, yes, if neutropenia is the only immunologic abnormality. Question, should a child with neutropenia be kept in isolation? Answer, no. Neutropenic patients may go to school and do not need to wear masks. Thank you for your listening.